Okay.
Okay, do you see anything now on my screen?
No, it's fine.
Fine.
No, it's fine. It's yes, very nice. So this is the 10th webinar of the Iraqi Orthodontic Society. We'd like to welcome Dr. Dalia El-Bokle, and she has a certificate of orthodontic training from the USA. She also is a diplomat of the American Board of Orthodontics, and she was a former professor of orthodontics in Cairo University, and she's the founder of the contemporary clinical orthodontic courses. She also has a private practice that's in Zayed Orthodontics in Egypt. She has given a lot of courses and lectures in international and local and regional conferences and meetings, and I was lucky to attend some of them. And we would like to welcome her today, and we really look forward to what she has to say in this interesting topic. Dr. Dalia, it's all yours.
Okay, assalamu alaikum, everybody. Hello. Thank you, Dr. Akram, so much for this nice presentation or introduction. And I hope everybody's staying safe and sound. In today's webinar, I will be addressing the role of disarticulation in orthodontic therapy. And I will try to demonstrate how disarticulation can be an efficient addition to our orthodontic toolbox. So the outline for my presentation today will include first a definition and the indications that I found for disarticulation or using disarticulation on my patients. I will go over the different types of disarticulation, the prerequisites, how to place disarticulation, and how to include it in the treatment planning stage. I will also go over possible complications that may arise during the use of disarticulation. And finally, I will be showing some of my cases and how to clinically apply the use of various types of disarticulations. Normally, the teeth articulate or interdigitate with an intricate mechanism, with a cusp to fossa or embrasure, cusp to embrasure relationship, buccally and lingually, in order to allow for the proper chewing of food. Disarticulation is defined as the act of disclusion of the teeth. It is achieved by asking the patient to open the mouth and then placing a bite turbo or a bite razor between the teeth. This way, when the patient closes, the teeth will have freedom to move in all three planes of space. Some like to call disarticulation bite turbos, bite razors, occlusal buildups, bite planes, or bite blocks. To tell you the truth, disarticulation has become an essential part of my customized treatment planning approach. Here you can see what I call a smart sheet. This is actually my diagnostic sheet that I fill and I write the problem list, the objectives and treatment plan. And here you can see this box where it says disarticulation and elastics. So for every patient, I try to find what kind of disarticulation would be most suitable to help me achieve the proper treatment. What are the indications of disarticulation? Here is a case that presented to me with deep overbite. What are the options here for bonding the lower arch without debonding the lower brackets? Well, maybe I can start on the upper arch first, intrude or procline the upper incisors, and then safely bond the lower incisors. Well, this procedure increased the total treatment time, but it is still a very valid option. So I look at my patient and I see that she has good incisal show. So no intrusion is necessary in her case. And I don't want to procline her teeth either. So my second option is now to bond the lower teeth more gingival in order to avoid any traumatic occlusion with the upper teeth. So let's see what will happen if we bond the lower brackets more gingival. Well, first of all, we will have a problem of oral hygiene and gingival inflammation and swelling. Another important problem that may arise if we bond the brackets more gingivally is inadequate torque expression. And let me show you how this can happen with evidence. These are two papers, two articles that prove that if we place the brackets more gingival, there will be changes in the expression of the torque that is built into the brackets. So for example, the first article demonstrates that there will be a 0.5 millimeter, that for every 0.5 millimeter of bracket displacement more gingival, there will be a torque difference of 4.2 degrees. Whereas this article shows that for every millimeter, there will be a 7.5 degree change in the torque. A third article demonstrates that for every 1 millimeter vertical shift cervically, there will be a 2 degree change for incisors, 3 degrees change for the canines, and an 8 degrees change for the premolars and molars. And you can appreciate that because of the difference in the sloping or the convexity of the buccal surfaces of these teeth. So for example, if we place the brackets 2 millimeters gingival on the lower posterior teeth, either the premolars or the molars, like so, we should expect the torque value to change from a minus 22 degrees to a minus 6 degrees. Not only torque differences, another study showed that placing the bracket 1 millimeter more gingivally than the 5 millimeter point could result in high torquing force, which, as you all know, high torquing forces can lead to root resorption. The third option is to use an elastomeric ligature with guard, like that provided or made by 3M Unitec. But actually, this is not readily available in many countries, and there is a lack of reports regarding their effectiveness. And of course, they will introduce friction in case you are using or you prefer to use a self-ligating bracket. Now, my fourth and last option is to place a bite turbo. This is the most common indication for disarticulation in order to protect the brackets from debonding in deep bite cases, while allowing the placement of the brackets at the ideal position from day one. So here, after placing the turbos, now no debonding may occur. The other type of protection that a bite turbo or a disarticulation can provide is when we are using ceramic brackets on the lower arch. Here you can see how this tooth here has suffered from attrition because of the use of ceramic brackets on the opposing tooth. And as Viatsis advised in 1989, ceramic brackets used on mandibular teeth should always be kept out of occlusion. So the second indication for disarticulation is deep bite correction. Anterior bite planes can be very useful in correcting deep overbite in growing patients, since they provide vertical clearance, reduce muscle hyperactivity, and permit extrusion of the buccal segments into the excessive freeway space. Posterior box elastics can be used to effect the extrusion of posterior teeth, incrementally increased if desired. So let's look at this case here that presented to my office with a deep overbite. And she had a bite turbo. You can notice the blue bite turbo on the upper molar here. So I had to remove the bite turbo and place it on the anterior teeth in order to allow for interocclusal clearance posteriorly. And with the help of box elastics, I was able to extrude the posterior teeth and at the same time achieve a correction of the deep overbite. So what's the effect of an anterior bite plane in deep bite? Well, this article here shows us that it will allow the eruption of the molars and premolars, which will improve the occlusal plane or curve of Spee, and it will also change the inclination of the upper incisors, which liberated the mandible from its retruded position in case of class 2. Another article that used anterior bite plane in deep overbite correction demonstrated that the lower incisors actually increased in or extruded a little bit despite the use of the bite plane. And one would think that using a bite plane would lead to intrusion of the incisors, where in fact this article showed that intrusion of the incisors cannot generally be expected as a result of this therapy alone. So the deeper the bite, the more incisal we should place the bite turbo or the disarticulation. So we would place it more incisally, otherwise we would have to fill all that space with the bite turbo. So now we can place our brackets. Turbos are commonly used for an average of 6 months, depending on how deep the initial overbite. What are the types of anterior bite turbos that we know? Well, the first one we have is the acrylic bite plane or the modified Nance appliance. So it is made with such a thickness to allow the interocclusal clearance desired. So when the patient bites, you can see that what can happen is extrusion of the posteriors with or without intrusion of the anterior teeth. Another type of the anterior bite turbo is the bonded resin turbos, as you can see in this diagram. Or you can use the bonded metallic turbos that you can buy and bond just like you bond the brackets. But these have been associated with a high incidence of breakage, and they are difficult to adjust, unlike a bite turbo made of composite or glass iron. This is another interesting design of a bite turbo called Bite Turbo 2 or BT2. And you can see here that there is a split in the middle. This slit allows for easy removal at the end of treatment using this type of plier here, or even a wine guard where you can just squeeze it and remove it by breaking the bond between the turbo and the incisor. The fifth type is a custom bite turbo that is digitally designed and constructed in a way whereby the doctor will be provided with the indirect bonding tray, just like the indirect bonding trays with the brackets. But here there is a space whereby you can fill it and then make your bite turbo. And there is a really nice advantage of using those digitally designed 3D printed bite turbos. They have been proposed by Lightforce, and the advantage is that no adjustment will be required, which is really nice to have as an advantage to reduce aerosols inside the clinic these days with the COVID-19 pandemic. If there is an increased overjet, a palatal bite turbo may need to be extended palatally or gingivally to ensure that the mandible does not slip behind the turbo. So here I'm extending it more lingually or more cervically. This way, the mandible or the lower incisors will not slip lingual or behind the turbo. Whereas if we have excessive or more increased overjet, then sometimes we may need to extend the length of the turbo even more. And in this case, we will have very long turbos like those ones. But a long turbo may be problematic for two reasons. It may be liable to break, and the patient will come often for you to fix it. And the patient may still be able to retrude the mandible to be bite behind it. So my advice here is to avoid those long bite turbos. Because if the patient bites behind the long bite turbo, then he might experience some joint pain. So to reduce the risk of fracturing the long turbos and try to avoid them altogether, you can place them on the upper cuspids initially, and as you reduce the overjet, then you can move them to the upper incisors. But still, if when placing them on the upper cuspids, you have to make sure that they are wide enough transversely so that the patient will not move the jaw sideways and bite again lingual to the turbo. Here is an example, one of my patients with a lot of crowding. And this is what I do initially. I try to find where I can place my bite turbos. And you can see here, I don't have enough room because of the crowding and the malalignment of the teeth. I cannot place it on two incisors together. So I try to look for the canine. Can I place it on the canine? So it's difficult to place it on the canine in this case because of the buccal position. So here is what I do. I use the modified Nance with the bite plane, and the advantage is that the bite plane in this case will remain functional despite any leveling that will occur with the upper or lower incisors. The problem with this design is the difficult oral hygiene. So I try to minimize the time of placement of such an appliance, and I remove it as soon as I gain proper overbite. The third indication for using disarticulation is the correction of open bite. And this is achieved by posterior intrusion and or incisor extrusion. So how do we achieve posterior intrusion? Well, let's look here. Correction actually is brought about by the forces, the occlusal forces on the molars that will result in posterior intrusion, along with counterclockwise mandibular rotation. And we always ask the patient, we give them chewies, just like the ones we give the patient when we start aligner treatment. And I asked my patient to bite on the bite turbos, the posterior bite turbos with the chewies, and do some squeezing exercises to help assist with such molar intrusion. Incisor extrusion can be brought about if desired with box elastics in the anterior region. So here is an article that was published in the Angle Orthodontics back in 2017 on the non-surgical treatment of skeletal anterior open bite endodontitis using posterior buildups. And here we can see the buildup placed on both the upper, first and second molars using band lock, and the thickness of these bite turbos was 2 to 3 millimeters. What they found was they had 1 millimeter molar intrusion, whereas they had about 1.5 millimeter extrusion of both the mandibular and the maxillary incisors. This resulted in a total of 4 millimeter overbite increase, while the mandibular plane angle showed a mean closure of 1 degree. And there was about 0.7 millimeter decrease in the anterior face height with acceptable long-term stability. Another article here showed that in which they used a bonded palatal expander that functioned as a posterior bite block, and they reported a 2.7 millimeter increase in overbite, as well as inhibition of growth in anterior lower face height. There is another design or another appliance called the Bure bite razor that was developed. It's a removable one where you can remove easily after the overbite is corrected. But I do see that this appliance may not be very comfortable for the patient. And maybe if we can develop another one that's more elastic, it could serve the same function, but maybe easier to use or more acceptable to the patient. So you can appreciate here how it is placed using an O-tie to the molar tube, and then it's rotated over to be placed on the cleat on the lingual side of the molar tube, of the molar band, sorry. The fourth indication to use disarticulation is to unlock the occlusion. And I find this a very important indication because a solid interdigitation may be resistant to both anteroposterior and transverse correction due to the cusp interlocking during swallowing or mastication. So the swallowing that we do per day ranges about from 500 to 700 times. And it's almost once per minute while we are awake. Our biting force can reach up to 32 kilograms, which is really a lot. And therefore, a bite turbo will facilitate tooth movement, especially in patients with well-formed cuspids, solid interdigitation, and a strong musculature. Here, there is the common example that most of us have used while in the residency program, a removable appliance with an occlusal coverage that acts as a posterior bite plane in order to correct a cross bite of one incisor using the palatal spring. The fifth indication is to facilitate tip and toe correction. And this you can achieve through selective positioning of the bite turbo on the tooth surface so that you can control both the inclination buccolingually or the mesiodistal tip of this tooth. Here is an example of a case that presented to my clinic with a mesially inclined lower second molar due to early extraction of a lower first molar. And you can see how the tooth is inclined mesially on the panoramic radiograph. So what I did for this patient is I placed a bite turbo only on the distal aspect of the lower 7 after I extracted the lower 8. And you can see how I extended the bite turbo more distally. And I will show you why later on. Along with an open coil spring, I was able to gain the space and upright the tooth from here to there so the patient could place an implant on that tooth. Here is another case whereby I can actually control the buccolingual inclination of the tooth just by applying the bite turbo on the part of the tooth that I want to intrude. So here, for example, or the common example of the hanging palatal cusp in the upper molars. Here I have the bite turbo on the palatal cusp to intrude it and to correct the hanging cusp issue. You can either place it on the palatal of the upper molar or on the buccal or lingual of the lower molar according to the direction of movement that you desired. Now we come to anchorage reinforcement. We can actually reinforce our anchorage using disarticulation and adjusted occlusal forces to such disarticulation. Fiorelli and Melson back in 2013 published an article in the JCO Enhanced Occlusion. They used triad gel to increase the anchorage in their cases or extraction cases. And essentially the buildups they used created deep intercuspal or vertical walls. Like you see here in this diagram, the vertical walls. And the authors mentioned that the anchorage can be treated successfully using such composite onlays, taking advantage of the ability of the normal occlusal forces to minimize or prevent the actual anchorage loss. The bite turbo can also stop or even eliminate a functional shift, both in the anteroposterior or transverse direction, by removing the effect of a premature contact, most commonly pseudo-class 3 due to upright upper incisors. So you can see here how the patient prematurely contacts the incisors together, and then there will be a forward and sometimes lateral shift in pseudo-class 3. So here we place a bite turbo on the incisors, and it was known as Catlan's appliance, as you can see here, in order to effect the correction of the functional shift, and also you can see here how it is inclined. The bite turbo is inclined at 45 degrees in order to effect the proclination of the upper incisors as well. So it will eliminate the functional shift by two ways: preventing the premature contact and then using the occlusal or incisal forces by the slope or the 45-degree slope in order to produce a labial force on the upper incisors. Here you can see the slope. And here is another version of the appliance where it is used to correct the single crossbite or the upper left central incisor. Dr. Neil Kravitz has also published an article whereby he used resin turbos in pseudo class 3 malocclusion. And this is a nice diagram that he has in his article showing how the turbo is placed over the lower incisors and angulated at a 45-degree angle in order to result in the labial movement of the upper incisor. It's always better to increase the number of teeth if you're placing it on the lower incisors. Don't ever place it on just one or a single tooth, so that not to cause traumatic occlusion or periodontal damage to that tooth. Here is one of my cases. Actually, it was not a mild case. It was a moderate case of class 3, and you can see it how she had a deep overbite as well as an anterior crossbite. Because she had also a functional shift, I was able to bond the turbo on the lower incisors, angulated, as you can see, and it really helped with the correction of her treatment. Now, this is an advice that I would like to give you, because like I showed you in class 2, whenever you place an anterior bite plane on the palatal of the upper incisor, you have to make sure that the mandible does not slip behind it. Well, this is the opposite here in class 3 cases. If you place the bite turbo on the lower incisor, as in this case, make sure that the patient does not slide the mandible forward to the bite turbo, because if he is able to slide forward, then the class 3 will become even worse. You will not be correcting the problem in this case. So you can see here on the side view how the patient is able to protrude. In this case, you need to make it longer, extended more to the lingual in order to avoid this problem. Now, I will show you how we can use the disarticulation in order to correct functional shift in the transverse direction. As you all know, a transverse functional shift may be due to premature contacts caused by a narrow upper arch. In this case, we can treat the condition by expanding the upper arch. So here you can see the narrow upper arch is causing a premature contact that makes the patient shift the mandible to the side. So how can we use the disarticulation to help us with that regard? Well, we usually use a posterior bite plane with our removable appliances that incorporate an expansion screw. But let me show you how this really works. So here I'm placing a bite table on the posterior teeth or a bite plane, and then using the expansion appliance or whatever kind of appliance, fixed removable, to move the molar in the buccal direction. Then the bite table is removed and the patient will be able to close without having to slide to the side anymore. The eighth indication is scissor bite correction. And this can be done by adding a ramp or a bite table with an angle in the direction of the desired movement. And let me show you how. So here is a case with, let me go back, with a scissor bite, because this is the buccal, this is the palatal, and patient opens the mouth. I place the bite table with the ramp like I told you. So when the patient bites, the lower tooth will hit the end of the ramp, and whatever treatment we are placing on the lower arch, a fixed appliance or whatever, this will help, the ramp will help the tooth to slide along the inclination of the ramp and will really help with the correction of the scissor bite. The ramp is then removed and the patient will be able to bite in the proper position. Now, I also use disarticulation a lot with class 2 treatment. And I call the type of disarticulation that I use the debibri or the debiber. I have actually recently published an article, a case report in the Ajodo only this month on the use of this method. And this is what it really looks like. It's really resembles a mini or a micro bonded twin block on the upper and the lower dentition. And you can see here how there is a slope in between with a 45-degree angle between the upper and the lower bite tables. So the concept here is I am applying the bite tables on the upper and the lower. So when the patient bites, there is a premature contact. It's a deliberate or intentional premature contact. And I am actually training and forcing the patient to move the lower jaw forwards by the use of the inclination in the bite tables in order to achieve a bite of comfort. So when the patient bites down, the occlusal prematurities are created, forcing the patient to slide slightly forwards, only about 1.5 to 2 millimeters. You can see the slope right there. And I like to maintain the slide with light class 2 elastics, especially during nighttime. During the daytime, sometimes the patient is adjusted to the new position. So there is no problem. I always train them to bite and slide forwards. And the next time they come to me to the office, they are biting just where I train them to bite. But what worries me is the night time, because during the night, the patient is relaxed, the mouth is slightly open, and the only way to maintain this position is by using the elastics. I prefer shorter elastics than the ones in this example. Here is a video demonstrating how those bite turbos or how the debiber works.
زي ما اتفقنا يجي لورا لورا
نفتح تاني، نفتح، نستنى لورا ونقفل ورا خالص، بس كملي قفله بقى، كملي. Another example for the bite turbos, or you can use it a functional or inclined anterior bite plane that I use for the correction of class 2 is placed on the palatal of the upper incisors. Again, inclined 45 degrees. And then I like to make a seating groove to engage the lower incisors. So as the patient bites forwards, the lower incisors can find a place where they are comfortably seated. Sometimes I do it in the retainer, as you can see, like this. This is an example of a patient, class 2 patient, with increased overjet and deep overbite. Actually, this is the one with the inclined bite turbo that I just showed you. And you can see how I was able to achieve solid class 1 occlusion and the correction of the deep bite. Well, you could also use a bite turbo for class 3 treatment, especially in mild class 3 cases where you are doing a camouflage kind of treatment. In this case, I prefer to use the bite turbo in the front in order to effect a downward and backward rotation of the mandible. And this really helps with the correction of the class 3. This has been shown in several studies that the clockwise rotation of the maxillomandibular complex does occur, as well as the occlusal plane. It has been demonstrated by Eric, Liu, and Cheng and Wang in 2018. And they showed that class 3 orthodontic camouflage usually focuses on the sagittal improvement of anterior crossbite, but seldom on the improvement of the maxillary vertical deficiency. So that's why we should be treating class 3 vertically, not only anteroposteriorly. Bake in 2004 also found that the Frankel appliance 3 can correct class 3 malocclusion in growing patients by a backward and downward rotation of the mandible. Also, it has been shown that class 3 correction using an interarch spring-loaded module will produce a similar effect by extrusion of the maxillary molar without any compensation seen in the lower posterior dentition or significant vertical growth of the mandible. And what will happen is the mandibular bodies goes back and downward rotation with increase in the lower face height. So the conclusions. Orthodontic clockwise rotation of the maxillary mandibular complex is an effective technique for orthognathic camouflage. Bite tracers and bimaxillary dentition extrusion could be more effective than single dentition extrusion with TADs in the mandible for clockwise rotation of the maxillomandibular complex and improvement of the occlusion and the facial profile in late teenagers with class 3 malocclusion. However, the comprehensive clinical effects and long-term stability need further clinical studies. Now we come to indication number 11. How can we treat occlusal cants and asymmetries using bite turbos or disarticulation? As we all know, facial asymmetries are very complex malocclusions. In many cases, the vertical maxillary axis or deficiency on one side is the contributing factor. Occlusal buildups have been proposed for mandibular repositioning in adult patients with skeletal asymmetry as a conservative alternative to orthognathic surgery. This is a paper that was published by Fiorelli, Merlo, and Melson back in 2013. And it shows how they do mandibular repositioning in adult patients with class 2 and asymmetry cases. And they also have a 2-year follow-up in this article. They did the investigation on 32 patients, and they did mandibular repositioning before the orthodontic treatment, up to 3.5 millimeter sagittally and 2.5 millimeter transversely. The patients who showed occlusal stability and no muscular or TMJ symptoms after 3 months were stabilized in the new mandibular position by orthodontic treatment. 22 patients showed immediate adaptation to mandibular repositioning with no muscular or TMJ symptoms, and occlusal stability was found in 13 patients, and they reported a partial relapse in 3 patients. So this shows us here how we can use bite turbos or disarticulation for cases that have asymmetry prior to orthodontic treatment. And what they use is triad gel, just like they used it before when I showed you their article on anchorage reinforcement using the bite turbos. And here they use the triad gel to they bond it to the occlusal surface of the lower arch. You can see here how they place it on the posterior teeth. It provides full occlusal contact using the triad gel, and they do test the triad gel and adjust it for proper lateral intrusive group guidance. I just need to make a quick remark on the mandibular repositioning technique. I think that this technique should only be used by those who are good in dealing with TMJ problems and those who can read the CBCT of the patient or document it before they start treatment and look at the condylar position and be very wary of the condyles during such a treatment. Just a note of caution. Here is a diagram of an occlusal cant in an asymmetric case. I just want to demonstrate how this can really work in good hands. You can see that there is both maxillary transverse deficiency here. You can see the maxilla, how the upper arch, there is a cross bite on this side. And there is also a vertical deficiency on the left side. That's why in this, in such an asymmetric patient, the patient, you will usually find that the patient, there is a shift to the left on closure. What do we do, or what can we do here, theoretically speaking, let's say? So we can place bite turbos on both sides, but the bite turbos have to be of unequal heights. So the one on the right will have to be thin, where the other on the left has to be thicker, much thicker. And these are usually placed on the very back molars, on, let's say, the sevens, the upper sevens. whereas the molars or the on the mesial of the sevens will not have any turbos placed on them on the left side. And what can be done is that elastics can be used on the left side to effect extrusion of those posterior teeth. Afterwards, the bite turbo on the 7 can be removed, and then the 7 can also be extruded. And this way, the occlusal cant can be leveled out. And like I said, assessment and close monitoring of the condylar position and the TMJ's symptoms and signs is required during such a treatment. The last indication for disarticulation is to prevent undesirable tooth movement or the side effects that we commonly see during our treatments. So this is, I'm going to mention a few examples like lower incisor extrusion in cases of distally inclined cuspids. As we align them, we always have lower incisor extrusion. So we can use a biplane to prevent that. Also, upper molars buccal tipping during expansion. In this case, we can use a bite turbo on the palatal aspect of the upper molar to prevent such undesirable buccolingual inclination. Also, lower molars extrusion during distal uprighting or when we are trying to open space for an early loss of a lower molar. Lower incisor proclination with intermaxillary elastics, retroclination with space closure. We can also resort to bite turbos, whether anteriorly or posteriorly, in order to help us avoid such side effects. Again, bite opening with non-extraction treatment. We can use a bite turbo on the posterior teeth to help avoid such bite opening. So here is an example to avoid the bite opening with non-extraction treatment. Here you can see I have an SN mandibular plane angle of 37 degrees, and I don't want to open the bite. So I choose to place bite turbos on the buccal aspect of the lower molars, as you can see here. So now we come to the types, the different types of bite turbos. Well, I can maybe have find only two types: a flat bite turbo that has a flat surface, or an inclined or pyramidal bite turbo. What are the prerequisites of bite turbos? They have to be easy to apply and remove, and that's why we prefer to use a colored one, so no damage to the enamel can occur on removal. We should always aim for even bilateral contact, because if we don't have bilateral contact, the patient will start bruxing. And bruxing is not good for the joints, it's not good for the muscles. We might end up in having pulp or periodontal damage, and we might even cause a functional shift if we are not sure that we have even bilateral contacts. Like I mentioned before earlier in the presentation, we need to apply the bite turbos on at least 2 lower incisors, 3 even better, in order to avoid periodontal trauma to the weak lower incisors. Bite turbos hopefully should be made to be self-cleansing without any marginal overhangs to allow their cleaning. And they should be removed once the goal is achieved. Bite razors should be thick enough to provide clearance with the lower brackets. Generally, the more posterior, the more bite opening and the less thickness that's needed. The more forward, the thicker the bite razor. Clearance should be provided both in maximum occlusion and during lateral excursions as well. To facilitate removal after treatment, there are two tricks that I will share with you. The first one is use articulating paper to mark the highest contact. So don't place the bite razor on the whole occlusal surface. Just try to minimize the size of the bite turbo so that it's easier to remove later on. And you only need to achieve the disclusion that you want. The second thing is only etch the central fossa of the molar, not the entire occlusal surface. Again, in order to be able to remove it easily at the end of treatment. A self-etching primer is really nice. If you can use that, it saves you time during the placement of a bite razor. So after cleaning the tooth surface with pumice, you can use the self-etching primer, pressing it firmly against the tooth surface for 5 seconds. Dry for 3 seconds. And then use the material of choice in order to make the bite turbo. Here, a micro brush is used to shape the bite turbo, and then you can light cure for the required amount of time as prescribed for the material that you are using. And this is how we use the silicone mold to apply bite turbo if you don't want to use the freehand technique. Again, another tip is to use just enough thickness to clear the lower brackets. Don't use too much so that the patient doesn't have a lot of discomfort. And here you can always ask the patient to bite. And you always have to adjust it in order to prevent breakage when the patient bites and chews on the bite tables. You can easily do that with the use of articulating paper to make sure there is no prematurity on lateral excursions. This is the freehand technique that has been proposed by Jorgensen, where you can just apply it with a micro brush and shape it and then light cure. And this is the mini mold that's readily available. You can find it in different forms and shapes for different teeth and different thicknesses. And here is a nice one that's made by Tiger Dental, where you can see this angulation on the instrument that makes it even easier to use than the mini mold. So now we are going to see how the anterior bite razor is placed. It's a very similar way to what we saw in the posterior teeth. We fill the mini mold with the material of choice, condense it, and then place it on the tooth. Remove the excess and then light tube. Here is a table showing the different materials that you can use to make your bite turbos or disarticulation. Like I mentioned, triad gel is very popular. Band lock is also popular. You try to look for one that's colored. The one that I find very nice to use is Kitak cement. It's readily available in Egypt. The only problem it's difficult to remove, and it cannot be applied to the anterior teeth. However, it's moisture insensitive, it's fluoride releasing, it's more resilient than the other types. There is no etchant required, and I can usually shape it with a wet cotton bud. So, and it's relatively inexpensive as well. But you can try all these different kinds, and whatever kind you prefer to use or is readily available where you are, you can use it. So how do you select where to place the bite razor? Do you place it posteriorly or in the premolar region or at the incisors? And before you place it, please consider the following. You have to look at the site, the size, the shape, and the biomechanics of the bite razor, and whether you are going to place it with or without braces, because the effect will be different. So according to the site, you can place it posteriorly, in the middle, at the premolars, or anteriorly. And you have to consider the vertical pattern before you decide the site. You also have to consider the amount of overbite, as well as the skeletal relationship. And like I said, the biomechanics of the required treatment. So for dolichocephalic patients, or open bite cases, or skeletal class 2 cases, we would like to rotate the occlusal plane like so. So the best way is to place the bite razor in such cases on the back molars or the posterior teeth. This way, we can intrude the posteriors, and you can see here that the forces, the intrusive forces, are distal to the center of resistance of both the maxilla and the mandible, and this will result in downward rotation of the upper arch anteriorly, whereas it will result in upward rotation of the lower arch anteriorly. So we will have this result in the end. As the patient closes, there will be also auto-rotation of the mandible, resulting in improvement of the class 2 relationship as well as the open bite. Whereas for mesocephalic cases, always aim for the premolars, because in this case, you will maintain the occlusal plane and the face height ratio. For brachyfacial types, I prefer to place the disarticulation anteriorly on the palatal of the upper incisors to allow for molar extrusion vertically, especially if there is a deep bite. It's always safer to select the site of placement ahead of time during the treatment planning stage. And just make a note of it in your treatment plan, because someone may forget when they actually see the patient where they were supposed to place their bite turbos or their disarticulation. So I believe I mentioned before how the anterior disarticulation can help with the correction of the skeletal class 3 malocclusion, as well as the deep bite cases. So we will have extrusion of the posterior teeth, resulting in a posterior rotation of the mandible. As for the biomechanics, I will show you some diagrams to demonstrate how one has to consider the site of placement of the bite turbo. For example, if we are placing an anterior bite turbo on the upper incisors, and here is the first example, where you can see the upper and lower incisors are almost upright. The green dots are the center of resistance, and when the patient occludes on the bite turbo, there will be intrusive forces shown by the red arrows. So you see the intrusive forces are slightly anterior to the center of resistance in the lower arch, whereas they are almost along the center of resistance in the upper. So there will be some proclination of the lower incisor in the first case, whereas the upper incisor will stay in its position. In the second example here, you can see that the upper incisor is a bit upright and the lower is more proclined. So when the patient bites on the bite turbo, the forces will be generated in the direction of the red arrows. So they will be lingual to the center of resistance of the upper incisor and labial to the center of resistance of the lower incisor. And let's see what will happen. This will result in more retroclination of the upper incisor and more proclination of the lower incisor. And in the last example, we have proclined upper and lower incisors. And the forces, the intrusive forces, would be labial to the center of resistance of both of them. So this will result in even increased flaring of both of them, which may be undesirable. So you have to look at what you really are trying to achieve. What is your objective? Where do you want your incisors to be at the end of treatment? And make the dots to represent the center of resistance. Make a diagram of the bite turbo on the lateral ceph and see where the forces are going to go and kind of predict the expected movement. Here is another example for the lower molar, whereby you can control the inclination according to the site of placement of the bite turbo. So mesiodistally, in this example, the force will be directed on the distal cusp of the lower molar, which is distal to the center of resistance. So it will result in distal tipping of that molar. Whereas if the molar is already mesially tipped to start with, here, like here, if the force will be directed only very, very slightly distally to the center of resistance. So there will not be a big moment resulting in the correction of the tip lower molar. That's why you should extend the bite turbo more distally so that the forces, the occlusal forces, will be more distal to the center of resistance to help you with the tipping moment that is required to correct the tooth position. Same thing applies for the hanging palatal cusp in the upper arch. So the more lingual you need to extend the bite turbo more to the lingual so that you have more or a bigger moment to help you with such correction. So really the resultant movement will depend on the position of the bite turbo relative to the center of resistance, and also will depend on the initial tooth angulation. And here is how I do it during the treatment planning stage by drawing the intended bite turbo, the center of resistance, where the forces are going to be dissipated, and how the teeth will move. This is a table that has all the features of the bite turbo, the function. It can intrude, extrude, or just protect the brackets from debonding. It can be placed anteriorly or at the canine, premolar, molar, in high angle cases or low angle cases. So you just put the table in front of you and just kind of make a click or a check on the position, either here, there, or there, according to your preference. It's just a table that helps me not to forget any of the functions or the criteria that I want to have in my bite table. So now let's go to the complications. Yes, it can fire back. If you use it improperly, it can fire back. And let's see how. The first thing, bite turbos can cause discomfort during eating and speech problems, especially when placed in the beginning of treatment. They can cause traumatic occlusion, like I mentioned before, if there is lack of even contact, which can result in increased tooth mobility, periodontal problems as well. They can result, or you can have wear and breakage of such bite turbos. It can result in loss of tooth vitality, undesirable intrusion or undesirable tooth movement. Patient can actually start to brux, functionally shift the mandible sideways, and may even develop TMD symptoms. Bite turbos can result in space opening, and I will show you some examples. And it may result in an occlusal cant if they are not equal or even on both sides. So how to deal with discomfort? Usually the patients adapt well to the bite turbo following the first visit. So just try to explain the procedure to the patient, confirm the necessity of the bite turbo, and explain that it is only temporary. Try to use the minimum thickness that you can, just to give you the aim that you need, which is either to allow for sufficient disarticulation, make sure there is no premature contact on lateral excursions. Always start with a thin bite turbo, and to get the patient adapted, and then add to it the following visit if you need to. Ask the patient to start a soft diet for the first few days in order to get accustomed to chewing on the turbo. Here is a patient of mine that was complaining of a deep overbite, and I will show you a complication that happened in her case. Because she had a deep overbite and an increased overjet, I needed to place an anterior bite turbo, but because of the excessive overjet, I was not able to place it on the palatal of the upper incisors, like I mentioned before. Otherwise, it would have been a very long bite turbo. So I opted for the canines. I placed them, you can see here how I placed them on the upper cuspid. And I was, I instructed the patient to start on class 2 elastics to help with the class 2 treatment, or the class 2 cuspid relationship, but the patient never wore her elastics. And she came to me maybe 6 weeks later with the space opening up between the lateral and the canine. To start with, we remember there was no space at all in the beginning upon placement of the bite turbo. And now the space is developing and increasing in size. And here you can see how big the space has become. And now I'm trying to place an open coil string to push the cuspid mesially in order to close the space that has opened because of the bite turbo. And here you can see I was getting there, closing the space. So the bite razor can be very powerful. It can open spaces. Now, another complication that I had in another patient, also when I placed the bite turbo on the cuspid, as you can see here. What happened was that the lower cuspid moved lingually to the bite turbo. That's why you remember in the beginning of the presentation, I told you try to make the turbo as long as possible on the cuspid so that the patient cannot slide the jaw sideways. So this is how she looked the following visit, how the lower cuspid moved lingual to the turbo on the upper cuspid. And you can appreciate here how the lingual positioning of the canine, whereas it was never lingual to start with. Also try to avoid bite turbos on weak teeth, like the upper laterals, the lower centrals, single teeth, or their opponents, periodontally compromised teeth, or those with a thin gingival biotype, or those with large fillings. Let's see. This case here came to me. She had an anterior bite turbo on the upper centrals, so we cannot see them, those upper centrals. And you can see here how her gums are starting to develop some recession. So I was not aware of that in that visit when I placed the bite turbos. And the following visit, 6 weeks later, the recession became worse than before. Another case that was referred to me from abroad, actually, this patient came to me. She had, it was an extraction case, as you can see, and the previous orthodontist had placed a white turbo on the upper molars, but she had a deep bite to start with. So always try to avoid placing a posterior bite turbo in a deep bite case, or you will never be able to correct the deep bite. As for removal, how to remove a bite turbo? Well, these are a selection of diamond stones that you can use to remove the bulk of the bite turbo using a high-speed handpiece, and then you can use the residue or the very remnants with the white stone and a coolant, because this white stone causes a lot of heat generation. This is an example how you can just squeeze a palatally bonded bite turbo with a Howe plier after making a slit in the middle. So you have to make a slit in the middle and then squeeze it off with a Howe plier. So now I will show you or share with you some cases. Here is a patient of mine, 12-year, 7-month-old, who complained of, he said that his front fangs, meaning his upper canines, have no space to come in. This patient was a class 1 malocclusion, mesofacial, and he had a deep overbite. He was an extraction space because he had a lot of crowding. So I removed the upper bicuspids, the lower right second bicuspid, and the lower left first bicuspid in order to help correct the midline shift in the lower arch. And I just placed a modified Nance with an anterior bite plane. And I waited for the cuspids to come in. And I will show you how effective the anterior bite plane was in correcting his deep bite. So as you can see, there is a time lapse between the photographs of 3 months. In 3 months, the deep bite was improving, and there was some space in the posterior interocclusal space. The molars were able to erupt into that space, extrude. As you can see here, overbite even improved, and the teeth are now contacting with no space in the posterior area on either side. Looking at the cephalometric tracings, the bite plane was able to achieve posterior extrusion, opening of the SN mandibular plane, increase in the A and B angle, flaring of the upper and lower incisors 75 degrees respectively. So I guess the bite plane was the forces due to the bite plane were anterior to the center of resistance of the incisors, which resulted in such flaring. Another case, a girl, 16 years, 2 months old, who complained of improper bite. As you can see, she had a scissor bite on the right side, over eruption of the upper right canine, first and second premolars, and a lower midline shift here. And this shift was mainly a functional shift to the left side. So you can see when she opened her mouth, the midline was different from the closing position. She had a missing upper right first molar, asymmetric narrow lower arch. The lower arch was considerably narrower than the upper. So I definitely needed to coordinate the arches by uprighting the lower right premolars and lower first molar. But how can I bond the lower right side with such a deep bite? And where should I place the bite turbo? These were the questions that I had when I was looking at her case. Since the patient had a steep mandibular plane angle, and because I needed to open the bite a significant amount to get enough clearance to bond the lower arch, I elected to place the bite turbo posteriorly on the palatal cusp of the upper sevens. So here is the posterior bite turbo, and it just gave me enough clearance to be able to bond the lower premolar brackets. So you will see how progressively the case improved and started to get the midline correction as well. And now you can see from here to there, to there, and here almost corrected. Now I removed the posterior bite razor on the 7th because I wanted to move the upper 7 forwards and close the space. At first, I thought I was going to need a TAD to do that in order not to put any strain on the anterior teeth, but I elected to use a pyramidal bite turbo or an anchorage bite turbo on the first premolar, as you can see, and get the anchorage from the occlusion of the patient with the lower arch, and I just placed a power chain to move the upper 7 forwards. You can see here the pyramidal bite turbo made of glass ionomer, Ketak cement. And here, as I was closing the space by protracting the upper 7. This case was 12 years, 11-month-old when she came to me complaining of upper protrusion. And you can see she had a really deep overbite. And a class 2 malocclusion. I was not able to place the bite turbos on the palatal of the upper incisors, so I elected to place them on the canines, as you can see here. And I used class 2 elastics to help with the correction of the class 2 malocclusion. The anterior bite turbo in her case allowed for the deep bite correction as well as for the overjet reduction with the class 2 elastics. So here is the center of resistance, the red dot representing the center of resistance of the upper arch, and how the upper arch will how there will be a moment on the upper arch which will help with the correction of the deep bite. This case was 14 years, 11-month-old, again complaining of an incorrect bite. You can see here that she had class 3 malocclusion with a bilateral crossbite. And the upper arch was tapered and narrow compared to the lower. Her Ceph tracing showed that she was a bit vertical and a -2 degree AMB. So I elected to place the bite turbo on the anterior. Actually, I placed it on the premolars. You will see here. And I used cross elastics to help with the correction of the transverse deficiency, as well as the class 3 malocclusion. So the turbos in her case provided disclusion or disarticulation to free the upper arch and to allow for the movement of the upper dentition in a transverse and an anteroposterior direction. So looking at her tracing, the AMB went from -1.7 to 0.8. Upper incisor remained the same almost. as well as the lower incisors. But the SN mandibular plane angle increased about 1.5 degrees. And I think that's how the class 3 was corrected in her case, by the clockwise rotation of the mandible. This case was 41 years, 8 months old, complaining of a crossbite of the upper right lateral incisor. She had a nice profile to start with. And looking at her occlusion, you can see that the lower molars were mesially tipped, especially the one on the left side, this one here. And if you look at the occlusal photograph of the lower arch, you can see how big a marginal ridge discrepancy is present between the lower first and second molars. So here I used the bite table. I placed it on the distal of the lower first molars in order to help get a clockwise moment to help with the correction of the tip in the lower molar. And this is how I placed it in the beginning of treatment. And that was at the end of her treatment. This case, 20 years, 4 months old, complaining of upper protrusion, and a class 2 case. She was offered a surgical option, but she refused. So I opted to treat her with extraction of upper bicuspids in order to correct her overjet of 6 millimeters. At first, I wanted to use TADs because I was aiming for maximum anchorage in her case. You can see here how I placed the bite turbos on the palatal of the upper incisors because she had a severe overbite, deep overbite. But at the end, I just used class 2 elastics and the pyramidal bite turbo for anchorage reinforcement instead of the TAD. You can see here I was able to achieve closure of the overjet as well as correction of the canine relationship into class 1 without having to use the TADs. You can see the remnant of the pyramidal bite turbo here. So this is the progress of her case during closure of the spaces. Now this patient was 11, almost 12 years when she came to me, again complaining of upper protrusion. She had an overjet of almost 9 millimeters, and as you can see, a bilateral full unit class 2. So here in her case, I used the debiber that I told you before about. This is her Ceph tracing and her panoramic radiograph. Her AMB was 5 degrees to start with, and she had she was slightly on the vertical side with an SN mandibular plane angle of 36 degrees. So that's why I opted to use the debiber or the debibbery on the first molars right there. And here is her position when she first bites on the deviber, on the bite turbos, and there is a premature contact, and then she will slide along the slope or the incline of the deviber. Now here she is in maximum intercuspation, and there is space between the premolars where I will be attaching some elastics to close, help extrude those teeth this way. So this is the progress of her case, and this is where we ended up. And I gave her retainers just before the COVID pandemic started. She came to me only a few weeks ago with a slight posterior open bite because she was wearing the Essex retainers 24/7 for the last 6 or 7 months. So I just asked her to stop wearing it except nighttime. So I hope the slight open bite will close the next time I see her. But you can see that she is a solid class 1 canine and molar relationship. This was her tracing. You can see the A and B went down to 3 degrees from 5, and her mandibular plane angle increased slightly. And this is her profile after treatment. This is my last case here. This is a boy about almost 15 years old, again complaining of upper protrusion. And you can see how he has scissor bite, a bilateral scissor bite, an overjet, increased overjet of about 10 millimeters, as well as a deep overbite. So it was a very tough case. And I tried to use the bite turbos at first to help me with the correction of the scissor bite, like I showed you in the diagrams in the beginning of the presentation. So here are the bite turbos inclined in such a way to help with the correction of the scissor bite. So as the patient bites, the lower premolars will touch the slope and hopefully slide buccally along the slope. So we went from complete scissor bite here to partial increased buccal overjet there. At this point, I adjusted the bite turbo in order to help me with the anteroposterior correction of the class 2. So I changed the inclination of the ramp to, or you can say that I converted it into a deviber on the upper arch only. So here I'm trying to achieve the rest of the correction of the anteroposterior relationship, trying to get a class 1 occlusion. And you can see here just placed a pontic for the missing lateral incisor. So now the take-home message. I think, I hope actually that I tried to convince you that disarticulation is a valuable tool that you can use in orthodontic therapy. In conjunction with the passive self-ligation and selective torques of the Damon system that I use, great results can be achieved. A good understanding of its action, method of fabrication is essential to avoid having or running into heterogenic effects. The choice of a biplane or biturbo always depends on fish facial type, the amount of overbite, the skeletal relationship, and the intended treatment mechanics. Disarticulation, in my humble opinion, should be always a part of the orthodontic treatment plan. Try to avoid placement on teeth that will undergo alignment, as once they move, the turbos will be out of contact and they will require replacement. But try to place flat turbos most of the time, unless you are trying to achieve class 2 or class 3 correction or a scissor bite correction. Try to place them of an adequate length or extension to avoid the mandible sliding backwards or forwards to the bite turbo. Try to avoid placing them on the cuspids if the mandible can slide sideways. And try to consider the condylar position. So they have to be always symmetric. Otherwise, the patient may become prone to TMJ problems. Thank you very much.